Hello everyone, in this video I am going to show a case of topical MSICS. This deeply seated eye was having inadequately dilated pupil and with dull astigmatism of +2 diopter. So to take care of this pre-existing astigmatism, tunnel was planned superiorly. The superior rectus bridle suture was not taken, as doing so would have caused tremendous pain to the patient. And also cauterization was avoided for the same purpose. A nearly flower-shaped scleral groove is being made with the help of 15 number blade, and using a crescent knife, a sclerocorneal tunnel is being fashioned. The tunnel is made closer to the nimbus purposefully to induce more SIA. It is to observe here that the limbs forceps in my left hand holds the conjunctiva firmly and provides me a good counter traction while I move ahead with the crescent knife. It makes my job easier. Now a side pocket is created on the left side and on the right side as well. After completion of the tunnel part, a side port is now made at the 9 o'clock position. The tripod blue dye is injected under the air bubble to extend the anterior capsule. The preservative-free intracameral lignocaine is injected into the anterior chamber, followed by lavage using the balanced salt solution. Now 2% HPMC is being pumped inside the AC to prepare the eye for the capsular axis. The conjunctiva near the side port balloons up, so to prevent it, an opening is made into the conjunctiva. By this time, I am good to go with the capsular axis creation. A C-shaped anterocapsular flap is being raised with the help of 26 gauge bent cystodome, and the same is being fashioned all around using the pupil as a guide. The rexus part is about to get completed, and we have circular and adequately sized rexus. The inner lip of the tunnel is now being created using 2.8 mm bevel up steel keraton. The inner lip goes parallel to the nimbus along this entire length. Doing so provides an effective valvular effect to the tunnel. It is to observe here that I am holding the external lip of the tunnel to get the good support with my left hand. Time for the corticocapsular hydrodissection. The nucleus is tapped at the center to release any entrapped fluid posterior to the lens. The fluid wave gets the nucleus popped out, and using the same cannula, the nucleus is tilted. The accumulation of the fluid in a deep-seated eye obscures the surgical field. Now HPMC is injected inside the anterior chamber, and with the help of a Sinski hook, the nucleus is being brought out of the bag. It requires multiple strokes with the Sinski at the equator of the lens, especially when pupil is not so well dilated. The whole of the nucleus is now being brought out of the eye using viscoaspiration technique. Viscoaspiration is a very nice technique which never allows anterior chamber to get collapsed after the nucleus is out. This technique is endothelial friendly also. You are less likely to face keratitis on next post-operative day. Once major chunk of the loose lens matter is out, It's now time for the cortical aspiration. The 23 gauge simple cannula is being utilized for the same purpose. The pupil has got further down by this time, and aspiration of the cortex through this size of the pupil is a real challenge. The struggle being encountered to get the cortex out from this quadrant can be observed. Now I am entering through the side port. The cortex aspiration from the side port is always a safe approach. It keeps the posterior capsule always away by keeping the chamber formed all the time. The remaining chunk of the cortex at 10 to 12 o'clock position is now being aspirated. By this time, all the cortex have been cleared off, and the eye is all set to receive intraocular lens. The single piece PMMA lens is being implanted inside the bag. The leading haptic goes under the pupil and under the anterior capsular margin. The IUL now being guided inside the bag with the help of Sinski hook. The free rotation of the IUL confirms the right placement. The residual HPMC is aspirated out, and also the hidden cortical matter is taken out and is aspirated with the help of Simcoe cannula. Once this is completed, it's now time for the closure of the side port. By now, we have arrived at the final step of the surgery, that is cauterization of the conjunctiva. And doing so brings us to the end of the surgery. After removal of the speculum, few drops of the betadine is instilled inside the eye. The patient is asked to blink the eye and rotate the eye. She did not feel any pain during the whole procedure. No patching is done and patient starts enjoying vision immediately. That's all. Thank you for watching.